yesterday, Shelley talked about moral injury and really gave you a nice overview of moral injury. And one way to work with moral injury is using prolonged exposure and maybe EMDR too. And that's something that Ole wanted me to cover. We wanted to have Professor Sonia Norman to give that talk. She developed the trauma-related moral injury treatment. Unfortunately, she really wanted to come and give a workshop, and she couldn't. He actually was in Ukraine a few weeks back, so she couldn't make another trip. But she promised to come and do a full workshop on how to treat moral injury in her specific treatment that she developed. But she was kind enough to give me some slides to share with you. So I'm giving her words. It's not my words. I hope I will be able to give her words for you. But we're gonna only cover the aspect that relate to prolonged exposure, because she has a whole therapy. If it doesn't work with prolonged exposure, you're still suffering from moral trauma. After finish, then you can do her own treatment, and then she will come and do a workshop on that element. So I hope it's not repetitive, because I think her language has a unique tone, and we're talking about potential morally injurious event, something that can lead to moral injury, and they usually they doing something bad. They are not preventing someone of doing something. And it's really conflicting with the moral belief. Not necessarily everything will cause you to have a moral injury. You can, I think Shelley talked about this soldier that saw another soldier taking a family out of the car and killing them. That's a war crime, and I don't know how to deal with that. And do I feel, some people with develop moral injury and some not. Some develop PTSD, but in a war, a lot of people are exposed to moral injury, potential events that can cause, but not necessarily will happen. So Sonia made a lot of research and looked how. So it's similar to if you take people that has drug addiction, about 80% of them have PTSD. But people with PTSD, only half of them have, substance abuse. So it's not. So she talks about people with moral injury, they're more likely to have depression, PTSD, anxiety. People with moral injury versus people without moral injury will have higher rates of substance abuse. And people, also another study, they showed that those people with moral injury have higher rates of suicide ideation, even plans and attempt committing suicide. So it's really affecting you. And in a very profound way. So the proportion of people with moral injury that have PTSD is very high. But if you take all the people with PTSD, it's not as high, similar to the people that were I gave a comparison to substance abuse. So people that really dealing with moral injury, they do have a lot of psychiatric issue involved with it. But it's not necessarily that you see a patient with PTSD that they will have a moral injury. So just be aware of that. So there is a lot. One of the reasons is the large overlap, and Sonia talked about suicide risk overlap, the intrusive thoughts, sleep, high level of substance abuse, negative cognition, guilt and shame. Anger, we talk about this a lot in the other talk about guilt, shame, anger, and how it's important to understand from PE perspective the moral development that you have, what the belief you have about self, what self is look like, so what are your core values. Remember, before you're starting treatment, you need to know the people and what they believe in and what they think about the whole word, how they think about other people, and then it's helped you to change. So they're talking about loss of meaning and purpose in life. They have social problem, trust. So there is a lot of overlap in PTSD and moral injury. Sonia point out to those hyper-arousal, hyper-vigilance, avoidance of reminder is very uniquely not really important to the mechanism of moral injury. So she really put those unique symptoms as separate from moral injury, the re-experiencing. And again, those are really fear-based mechanism that we want to really help the patient extinct the fear in PTSD. That's not exactly what drives moral injury. The moral injury, the intrusion, is more in like depression, rumination, correct? You have rumination, I'm a bit. When you work with depression with severe rumination, that's very much like the moral injury picture that you see. You can memorize this, you don't have to show it again. So from all what Sonia Norman did in the research in the last 2 decades, she really realized that evidence-based PTSD treatment, PE, EMDR, CPT are really good in treating moral injury. And if not just the PTSD treatment, because as we mentioned, not all people with moral injury has PTSD, so you can do spirituality integrated cognitive therapy. There are unique novel moral injury treatment, the acceptance and commitment treatment for moral injury, and there's what Sonia developed herself is the trauma-informed guilt reduction treatment that she will love to give you a workshop on soon. Again, you can use your spiritual leader, like chaplain, as a source of comfort and dealing with guilt, shame, and asking for forgiveness. Sometimes a priest that can forgive you will be powerful enough as a psychotherapy if that's what your core belief and you believe in forgiveness. So they can be done. It's not something that you should not consider talking about with your patient. And there is another, when trauma-focused psychotherapy fail, sometimes she recommend also impact of killing treatment. I don't know, I'm not familiar with that, but that's something that you definitely highlighted as a potential way of treatment. So trauma-focused treatment really can reduce moral injury, guilt. Guilt can be like, as I mentioned, residual symptoms after PTSD. And there is high correlation between PTSD and guilt, but the literature is mixed, so it's not necessarily always going to help. That's the reason that we might need more treatment after that. So Sonia developed what is called a moral injury distress scale, and I think it was translated to Ukraine, I believe so. And I think we would like to have a copy for you at the end of the workshop. We'll email to you. And you can, if you sometimes doubting with your patient if they have it, you can just give it to them and see. And it's looking how they reacted on their own act, how the act violate their own moral value. And you just rate it, and the rating, after you give it to your patient, it will give you a nice breakdown, and it say, score above 27 is highly probably that the patient suffering from moral injury. That's an indication that you want to go with that route of treatment with those patients. So consideration of this treatment. You have to be, again, it's really like being patient with the patient and listening very carefully. You want to understand, really, be non-judgmental. That's a major component. Let the patient feel that they are safe to share with you everything about what happened. Really empathic stance, what Sonia really highlight. Make sure that you stay hyper alert to your own assumption about, those moral value, and you not project your own value to those patients, because then it's a mess. You're becoming like a teacher, and then you're going to create what is called a therapeutic rupture between you and a patient. You have to be extremely non-judgmental. And Sonia highlights something very important. It's not your role to say it's not your fault. This is not the way to go. I know that maybe we got conflicting, but for Sonia is the notion that we are not making this judgment, because sometimes some guilt is appropriate guilt. Of course, we don't want to take it away. And this is a nuance that one should be able to tolerate, that we all make mistakes sometimes. We're not immune for making a mistake, and maybe there is a place for forgiveness. Okay, but going into the route that this is not your fault, that's a wrong assumption by the therapist, and remember not to fall into that trap. And what I use is really what is called hoovering attention for myself, is just listening. And let those ideas fall into my ears when the patient talk about it, and make them feel that it's a safe place without making any judgment. I just write down. What does that mean for them? What the act means to them? What does it make them feel? Stay away from making any judgmental, and don't try to correct all the time. Don't try to fix. Don't feel that as a pressing issue. It's so important in this process. Then patient will trust you. So again, working toward understanding and processing all trauma-related emotion, not just fear. Remember, John over-focused around the fear. Remember, when this soldiers that was in a firefight, it wasn't the fear that we talk about. I'm sure he was afraid, But this second that he made the decision to shoot the kid, it wasn't fear. It was a moral dilemma that he was dealing with. But sometimes, and I see in trainee that sometimes there is something so grotesque. People are shooting, people are killing, and it's pulling the attention because it's so cinematic, it's so robust. But the nuance, the small stuff, the second that he as a soldier need to make decision, I'm going to shoot that kid, was really what driving this event. Again, don't make assumption, just listen, and work toward making moral injury reactions more adaptive. Some level of guilt, as I mentioned, and feeling a little bit shameful, can be really therapeutic by itself, and acknowledging that. Okay? And the most thing is making meaning together. So why prolonged exposure is really good? Because you're going over the trauma so many times. You have so many opportunities, so much materials come out. That gives you what I call gold, and again, the rationale for prolonged exposure is to overcome emotion. And that's also emotion that you don't want to deal with it. Bad things that you've done, you want to avoid it. You don't want to feel the moral pain and the agony that involve, But the fact that you're doing it and going over it over again, Sonia thinks this is like the best place for her, and she's really big advocate for PE, not just me. We are both have this bag of PE. It's give you a lot of material. There's a lot of material to work with the patient, and it's a great opportunity to reshift really belief about guilt, shame, and make it tolerable. So in PE, when we're doing traumatic recollection, a value was violated. Okay? And the trauma underlies the moral injury. And how do we express those values other than suffering? So one of the mechanisms that we know in psychoanalysis is undoing. Okay? You try to correct. But there is a very different in this psychoanalytic because the undoing doesn't really correct what you have done. And try to conceptualize it. I'll give you this. Remember, I told you about this high-ranking officer. He was a battalion commander, is lieutenant. I don't remember the English, like very high-ranking officer, and killing those two Iraqis. So he was called by the Iraqis Captain M. He was like, by the Iraqis themselves, he had a very high status, so he felt really immune. For his PE, I was really focusing on really understanding his omnipotent control fantasy in this, because he was going and they were doing stuff and they were successful, and he felt that he is immune. He's really like, and Arab local respected him. He's like, and he didn't realize that behind it they are really plotting to kill him. Nobody really loved him in terms of the enemy, but there was the fear and respect. So what happened one day, they were in ambush, and I don't remember, like 4 or 5 of his soldiers were killed next to him, and he was really furious. He felt out of control, extremely out of control, extremely angry. And then a few days later, they went and captured a car that in the back there was blood. And maybe there was like farmers that took some sheep and there was blood, but in his head, he believed that the blood was of American soldier. And he took them and interrogated them. And he is an interpreter, and his interpreter tells him, no, they are nothing to do. They are not, Iraqi insurgents. They are really, really regular people, and denied any involvement. But his anger was so fuming that he couldn't not contain it anymore, because he also not just had this fantasy that he's able to call, he's also really denied his fear and anger across this. And again, he lost it and killed those two. Cold-blooded, with no reason, killed two innocent people. So now, moral, we're doing prolonged exposure. But then, he's coming, he's discharged from the army. Because he's high rank, I would have to be careful, because he assumed a very high ranking position in a company that deal with commodity trading. Okay? And his company bring stuff, commodities from overseas on ship, big ship. The commodity technically needs to be inspected. They send samples. Until the samples are not clear, you're not supposed to unload the ship. But his company say, we know the good is good. We pay for every hour that the ship on the dock, $10,000. Let's unload, and we get the positive results. And he got so furious, His fantasy was to kill the CEO of this company, because he's cheating the government. He is doing something very horrible, and he started to develop fantasy that he wants to kill his CEO. But what is this fantasy of killing CEO, installing back the justice? It was so obvious that he's undoing the killing. Because, okay, you can fully complain, but this intensive, those strong fantasy that he needs to execute the CEO because of, financial, and you start to process the symptoms. You understand how this guilt of undoing can really come in those patients that suffering from moral trauma and moral injury. So this is kind of took the whole treatment into processing this fantasy and undoing and understanding that what he's trying to do most of all is, find a correction action to, by killing his boss, he will undo the bad things that he done. So moving and understanding that he needs to accept that he really was, committed a crime, but this crime was because he couldn't deal with the stress of war in a way that was adaptive, and coming to forgive himself and understand the situation was what relieved him from this fantasy to kill his boss. But for me it was scary, because when you have some ideas that you have a target, and this was a clear, I had to make my own judgment, Am I taking the risk and reporting because he has homicidal? And I had some hint that he was not going to do it, but I was scared. For weeks, I was scared that this guy, he already killed two people. I have no guarantee, and this is, but you can end someone's life. So sometimes we have a lot of responsibility. And it's a very high-ranking people, like Lieutenant General, it's just, and you want to be careful because, you can send them to jail, and luckily, that was a relief. But the other more adaptive way of correcting, so there was a program in the US to allow interpreter to get a special working visa, and he worked very hard to bring his interpreter out of Iraq and give them, working visa in the US. So there is adaptive corrective action, but we have to be, again, so there is different way. One can be extremely maladaptive, especially undoing.
Ivan, can you talk slowly? Can't translate.
So there is different way of correcting, and doing something to undo your scene. It's sometimes, can be very, very dangerous. You need to find this line of making corrective actions that are really bring you to a place that you feel that you can forgive yourself and do a good deed here. Helping someone to restore and build a life, it's really right. Killing your boss, that's not a good way to move forward. So again, the goal at the time is not reducing emotion, but accepting them again and be able to manage them. That's what we teach people a lot of time. You are in control of the emotion. Feeling those emotions is appropriate. There is appropriate emotion. They have rule. It's when we get in trouble when we deny this emotion, or we don't understand the true source of those emotions. And in PE, expand the context. Let them talk about those feelings. Encourage them to talk as much as they can. Ask always, what does it mean to you? What does it make you feel? You want to pick exactly into those avenues that make the patient elaborate so you can understand where they're going to and what they're feeling about those. And that's what really helps PE to be the great place to do that. The goal, is letting those emotions be expressed and behavior repertoire really be appropriate to what you're experiencing. And we always deal in prolonged exposure. That's why I combine those. You're dealing with fear, The fear that you're going to die. It's the reason that this girl killed this civilian, because in her mind there was tremendous fear that she cannot longer contain. So that can give her a rationale that she is not a bad person, And you are in a context, as I mentioned, war is a psychotic scene. People are shooting at each other. People are burning. This is not reality. It's just some kind of a very distorted way of thinking, because that's in other contexts it's so immoral, and then in some other context it's the way of living. So it's hard to the mind to jump from those places. So the feel that she's going to be afraid in real life, but she needs to know that she's not going to kill anyone again. That was one of her bigger fear, that if she's going to feel again so much fear. So one important thing is not to put yourself in civilian life in situation that you'll be in fear. You don't want to recreate situation that someone being, raped over and over, and you're going to be there again and think it's not going to happen again. So always this kind of letting those people know that you can prevent. It's not a war. So you can always move out in a certain environment. You can make changes. There are things under your control. We talk about guilt and shame, grief and disgust. All those are extremely important feelings that one needs to present. So again, I'm trying to do my best to give your insights from Sonia Norman, but she also talked about this in desensitization phase, when you're doing the bilateral stimulation. In this phase, you really want to work with the patient around those moral conflicting memories and see how the patient takes it from there. That's something that is also a really good place to work with patients using EMDR and that specific phase. And then those insights that come from that phase of bilateral stimulation, is worried that you take the patient into the installation and really make it a whole new integration process with the patient. So that's a really good part of the patient, that there is a lot of safety in this MDR bilateral stimulation, that they can really engage on those, sometimes disgust of self, sometimes, the fear, guilt, and shame. This is a very safe kind of spectrum for them to really deal with those emotions. So kind of really, she feels it's another way to work toward that. So at the end of the PE or EMDR, you have to think, PTSD is better, but is moral injury is better? And sometimes it's not. So again, she said, if then you need to go and other paths and add on psychotherapy, her, trauma reduction, the guilt mechanism. And again, I promise Paula that you will come and do a full day workshop here, teaching you how to do this treatment, or another, using spiritual, church services, other way of making patient suffer less and try to deal with it in other. But we know, and Sonia talked about it, she is really, really seeing encouraging results from research using it within the context of prolonged exposure. If you touch it, as you know, don't ignore it. And I said, do you have the questionnaire translate to Ukraine?
Which one?
The one that she developed.
Moral injury.
No, we don't have it.
Okay, I think she said she can send us a copy that we can distribute, so people can use it in the clinic to work with that. So again, that's kind of the message that Sonia sent to you through me, and saying, this is a really great opportunity for people to use the PE that we talked in length before that to deal with moral injury. So what we'll do now, I didn't have time to take question on prolonged exposure and moral injury, so it's kind of good time for now to bounce some question before we go out to lunch.
Моє питання про той випадок, що ви розповідали про генерала. Скажіть, будь ласка, коли він звернувся до вас, ви спочатку розмовляли про цей випадок, що він хотів вже в цивільному житті, в компанії так робити, а потім вийшли на ту історію, що була у нього в армії. Чи він спочатку розповів про свій бойовий досвід? Як це було в свідомому роботі?
He came to my clinic to get treatment for the post-traumatic order for killing those two civilians. So that's how the treatment started. But in the sessions that I learned, I mentioned we have to do like 2, 3, 4 sessions of case formulation. He talked about his life and his family and his kids and how he grew up, and he brought the fact that he brought his interpreter. But then he said that recently he have very strong feelings about, he really like his company doing these awful things. And slowly through the PE, he started to express, when he felt that he trusted me, he threw up. He gave me this information that he's considering of killing his CEO. But the focus of the treatment was, again, prolonged exposure. He repeatedly, recalled incidents. There was many incidents that happened that he just brushed away. That's what, again, the denial of fear and the notion that I conceptualize, the omnipotence control. But again, when we did the processing of the killing, I started to integrate the undoing and how it's so related to each other. That why he have these strong fantasies all the time to kill his boss, because it's stemming from this moral injury, the pain. that involved that he just killed those 2 Iraqis with no reason. So the focus of the treatment was the post-traumatic stress disorder. The secondary outcome was the dealing with moral injury and taking care of the defense that was undoing, killing his CEO in civilian life.
I just want to clarify. So the patient in general, the thoughts appeared. The thoughts about killing a CEO appeared while he was in your therapy.
He admitted while we was in therapy. He came, I have a bad PTSD, all the symptoms. He came to the clinic and asked to be treated by me. And
Please talk.
so, yeah, he came to the clinic with a presenting problem. I have PTSD, served, in the army like 20 years, was in Iraq, a lot of shit happened. I want treatment for PTSD. And then you start to know the patient, and it didn't come immediately, He had to trust me at one point to admit to those thoughts. So it took some time during the treatment, but without that, I would never be able to really to make sense of all of it.
Добрий день. В мене питання.
Just a second.
В мене питання стосовно методу. Ви працюєте з пролонгованою експозицією, але також з травмою з ПТСР, добре працюють також наративна експозиційна терапія і EMDR. Ви використовуєте пролонговану експозицію, тому що ви вважаєте, що вона краще працює з травмою, чи це ваші такі особисті преференції?
So, again, I want to make something clear. Remember, I talk about memory consolidation and the notion that the memory, when we recall it, is labeled, is changeable. We can work with it. And someone highlighted, I have to remind you that we know from research, at least 10 minutes there, you can change it when you're working with the patient and processing, and you can keep it alive, of course, when you process it. So, but the window closes after several hours, but it happens in life all the time. It's, we think about things, we treat ourselves. I don't have like my PTSD went on because I was thinking about it. I was processing about it. I talked to a friend about it. I didn't. So some people will get, let's say, TMS, and suddenly you charge a prefrontal cortex, and suddenly they're able to feel safe to engage, and they maybe do prolonged exposure, but instead they think, and they go home, drive, and think, oh, I'm so nervous. I'm here I'm in Ukraine, in Lviv. I'm not in the front line. It's okay. Maybe it will be a missile, a drone, but yeah, most likely. And what happened? They think about it themselves because they were charged. So not that PE is but for those patients that are not able to access the memory, it's so fearful. So written exposure gives you time, but I don't feel it's necessarily, it always hit because it will hit X amount of subject. It will let them do this process. But for the cases that I work with, the most severe one, it's too hard. So I feel that PE gives me many more tools than just letting the subject write down the story, elaborate from week to week, and it's helping a lot. But again, it's something that I relate. I feel that I can bring the patient a lot of meaning that otherwise he will not have if they do just written exposure therapy. I think that's bringing the analyst in us to the process, and I think patients value that. We have in the clinic written exposure therapy, but I see that it's different because the insights are less deepened. Not that we need deep insight, but I, as a human being, I believe in deeper insights. I think it gives you more. But is it necessary? I don't know. So it's kind of, I'm biased. We all biased in some way, but because I believe insight, understanding has value in life. You know, Beck said, "Oh, I don't care what happened. Let me know what the problem." He was an analyst, but he said it's all bullshit. Just I'll say it's right, wrong, yes, no. You get better, same way. But again, we know that even CBT is better when you integrate meaning and knowledge of where it's coming from. Not
Nice expression. Even CBT.
Thank you.
Доброго дня. Хотіла спитати, коли ви працюєте в сесії пролонгованої терапії, чи буває у вас так, що, наприклад, пацієнти, доходячи до гарячих спогадів, наприклад, починає агресувати, тому що йому боляче дуже, да? Чи, ну, що ви з цим робите, з цією агресією? І як взагалі, чи можливо ви просто кажете йому, ви агресуєте, тому що вам зараз боляче, тобто ви звертаєте на це свою увагу. Як ви справляєтесь? Як ви з цим справляєтесь? І чи були у вас взагалі такі випадки, коли дійсно пацієнт агресував? Чи все ж таки ні? Дякую.
I would say that on the opposite. Most time they are so afraid of their aggression that they're not letting themselves express that. And when it's not because they're afraid of it, that they will come a raging, angry person that will destroy everything. And that's a really scary fantasy. I actually, you know, sometimes encourage to do what's it's called instructed imaginary scenarios with the patient to allow them to express. Say, you know, you are, you know, with this soldier that did something that's horrible, and I want you. Let's imagine you standing next to him. I want you to feel the anger. I'm not afraid, and again, it's just that it's your safety, and you need to see if it's someone that is intoxicated, or you worry that they will have like outbursts of anger toward you. That's something that you need to think. But I don't think I heard in the literature that patient in PE like hurt their therapist, and I don't know if you heard about any cases like that. I do encourage because they're so afraid of that aggression. And you think about a rape victim that I say, I feel that I want to punch this man and break his face, and you sitting here and just not feeling this anger, and I'm exploding, so I'm using the here and now. It's called in psychodynamic, you know, interpersonal psychoanalysis. You use the here and now, and you identified how you feel in the here and now to give those patients those emotions that they are not experiencing. And I encourage them to have this feeling, because if you're not going to express this aggression, just going inward usually. That's really like one of the causing that we have this. Yeah, you are better. You did a lot, almost as many PE as I did.
Я хотів додати дуже важливе до Ілана, бо він каже, що він не бачив і не читали ми про це. Це правда. Якщо експозиційна терапія є правильно підготовлена, якщо пацієнт отримав відповідні знання, що це за терапія, він знає наперед, що він може почуватися з тими чи іншими неприємними почуттями. Якщо ми створили з вами безпечний простір протягом тих 2-3 підготовчих сесій, так, що він розуміє, що він собі може тут дозволити більше, ніж він собі дозволяв інше. тоді пацієнт, коли ми не насилуємо його, так, наприклад, часами викликається такий контрперенос, ну, бо там ж треба повторювати енну кількість разів, і ти бачиш, що на другому разі він не може дойти навіть до середини історії. То тебе кажуть, ну давай в голові. А в надії, я кажу, слухайте, якщо ви не можете сьогодні, давайте продовжимо завтра. Тобто ви не насилуєте його, ми не насилуємо його чи її. І тоді пацієнт навіть після найменшої експозиції наступного дня приходить значно кращий. Деколи, чому я так люблю експозиційну терапію? Бо я бачу її результат. Сьогодні ти прилипав до крісла, сьогодні ти весь мокрий від страху. І думаєш, Боже, що ж буде на наступного разу? А наступного разу зовсім інша людина. Тому правильність техніки, повага до пацієнта, безпека пацієнта, не наша, є дуже важливими компонентами того, щоб цього не ставалося, що ви кажете. Якщо це стається, або пацієнт психотичний, і ми неправильно поставили діагноз, або ми порушили правила терапії. Ми в будь-якому випадку винуваті.
So beautiful. There's a lot of questions. You want me to run?
Як часто ви ділитесь досвідом своєї історії з пацієнтом? Як часто ви ділитесь своєю історією з пацієнтами? Чи ділитесь?
As a soldier? Not necessarily. I don't think most of the patient I do not.
Bad habit. Bad habit.
Bad habit? I should do more?
No, bad habit to share.
Yeah, I think I want the patient to see me as a blank container that contain him without pre-assumption. And I let them, again, I'm still asking questions, although I know the answer, that they think that I say it's very powerful for them to teach me about the military, about what they went through. So with the general, because he was higher ranking than me, I was only a captain, I did share, because kind of I felt that it was also something that he helped him trust me more in this process. But I think that's the only time that I disclose, and I did hundreds of cases, like 20 years doing PE now. Yeah, no.
Так, чудово. Я бачив на слайдах, що у вас були також ситуації, коли військові страждали не від ворога, а від своїх побратимів, від керівництва. І мені було б цікаво почути ваші кейси або ваші побажання, як таку терапію робити краще у таких випадках, як діяти краще.
Two things. Suffering. I need to clarify, because he says suffering. I know there is some commanders that are abusive and treat the soldier very badly. That's one thing. Or you asking about soldier that being killed by friendly fire?
На слайді було, власне, якщо я правильно розумію, про дівчину, яка отримувала зґвалтування регулярно від свого командира. І я просто міркую в цьому ключі, що людина, яка виїхала з лінії фронту, якщо в неї травма від ворога, вона може для себе це сприймати м'якше. І значно по-інакшому сприймати це, якщо це відбулося в колективі з її близькими, з тими людьми, з якими вона воювала по одну лінію фронту.
Yeah. So, yeah, I didn't have time to talk about this female soldier. And the structure in the military is that, it's very hard for a female soldier to complain about commander officer, even it's encouraged. But the material is in the processing was around a lot of the emotions and the betrayal of the military. So it's over compacted, but still there is anger, the humiliation, the helplessness. Those are all shared. So a lot of feelings are shared across trauma. Here is another layer of betrayal that we process too because you want the army to protect you, to be like, it's like a unit of brothers and sisters that fight together, and then that betrays you. So that's a big other notion that we worked on. And again, was compounded by, why she began to, there was also complicated because she always felt as a child very abandoned and unloved. So there was also the conflict about feeling loved and careful over, even if it was violent and unwanted. So it's very complex. So it's that's that specific case. I didn't have time to talk about it, but across rape, there's a lot of commonality, even if it's happened in the military or not. Here's again the betrayal, and like I had another soldier that was so angry with his commander because he treated them so badly during the year they were in Iraq. But he blamed the commander for the suicide of his friend. But it was nothing to do with the suicide of this friend. And I realized that the anger toward the commander was a displacement of the anger toward his own friend that never came, talked to him about his despair, but it was too scary for him to express the anger toward his friend. So he displaced it to the commander. Commander can be shit, but that doesn't kill people. So talking to the soldier and understanding that I can love my child, but I can also be angry with him at the same time. And my anger will not destroy the object. It's not gonna. So he can have this dual feelings toward his friend that killed himself in the military. Still love him, but be angry that he never came up to him, never asked him for help. And he was like in dark. Suddenly, one day, his friend shot himself after a year in the war. And that's really we actually made him go to the grave of this friend and say to him, express the anger, fuck you, sorry. Why you didn't come to me? Why you didn't ask for my help? And it's really made a huge change. So again, sometimes we take and displace feelings toward our system. Yeah, military is a shit. I was there. It's not fun.
Окей. Будемо закінчувати потихеньку.
There was two things I have to say something short.
Yeah.
Someone asked for. So there was a request earlier to say two things about the propranolol intervention in blocking reconsolidation, and so there is a preparation sessions before any drugs that we do that alter experience. MDMA, ketamine, you prepare the patient before that to what they're going to experience, so you spend 1 or 2 sessions. So we're going to talk about it as emerging treatment later on. And another question from the gentleman was how to translate the success of good PE to civilian life. So I think it's very good to move to supportive rehabilitation approach with the patient when they regain some control over those aspects of their life. Encourage them to be engaged in social club of veterans, or try to re-engage in more stable relationship. So you want to translate it to outside the therapy, because you get a lot of gain, but then you want to sit on the ground and continue like in some more supportive. I think sometimes it's very helpful. Sorry, that was too much.
Насправді немає унікальної панацейної терапії. Так? Коли ми працюємо з пацієнтом, ми насправді маємо бути трохи аналітиком, трохи КПТ-терапевтом, трохи соціальним працівником і бачити, як воно є, і тоді буде лікуватися. Нема такого, що пішов, полікував, пішов. Як ви побачили, пролонгована експозиційна терапія є широкою, вимагає багато знань, багато сміливості, багато думок, багато супервізії. І найпарадоксальніше, чим кращим ми є PE-терапевтом, тим глибші емоції і спогади ми дозволимо пацієнту побачити, і тим важчі спогади і випадки він принесе в терапію. І тоді ми маємо задачу, вже тепер ми травматизовані, і ми маємо задачу. Він принесе в терапію, що він когось вбив, або хтось вбив його друга, або хтось вбив дитину, або він вбив дитину, або він вбив жінку, і так далі, тому подібне. Але прекрасно, що сьогодні сказав Ілан, це є те, що ми не повинні давати оцінку цій події. Ми повинні створити умови і обставини, в яких цей пацієнт зробить своє reprocessing. Він передумає це, продумає це і дозволить собі жити з жалем, який він має. І це є найвища краса пролонгованої експозиційної терапії. Тому потихеньку є терапії легші, і вони також успішніші. Але коли йдеться про якийсь важкий стан, я дуже люблю працювати в парі з EMDR-терапевтами. Але терапевтами, не асист і ні. Тому що ми іноді йдемо паралельно до одної та самої травми і ніби підганяємо один одного. Це колись була наша терапевтка, вона з нами працювала Олена, а тепер Міра і декілька дівчат, що ми супервізуємо один одного і допомагаємо один одному заглянути за ці очі смерті. Окей. Thank you very much.
Thank you, everyone.